Okay. Good morning on this sunny summer's day, being the 29th of July 2024. Welcome to the Health and Care Overview and Scrutiny Committee. Welcome to those that may be watching this on the webcast. This will be available for playback for 12 months on our website here at the County Council. So, if I may, go straight into the agenda. Item 1, we have apologies.
Good morning, Chairman. I've received apologies from Councillor Philip Atkins, Councillor Edgeler, Councillor Hood, Councillor Chapman, Councillor Prestwood, and Councillor Long with Councillor Norman as substitute.
Thank you, Zach. Item 2, declarations of interest. Councillor Atkins. Oh, you're just waving to each other. Oh, how polite. Councillor Bernard Peters. Thank you. Okay, moving on to the minutes. Hopefully they'll be fresh in our minds. It was only 17th of July 2024. Am I okay to sign that off as a true record? Yeah. I'll sign that later. Okay. Moving on then to item 4 of our agenda, the plan for commissioning care homes and development of additional nursing capacity. We've got Councillor Jeremy Pert, a Cabinet Member for Health and Care, and we've got Dr Richard Harling and Helen Truesdale. Councillor Pert, I assume you'll introduce?
Thank you, Chair, and good morning, everyone. First of all, can I just start off by congratulating you, Chair, on your elevation. It's my first opportunity to congratulate you, so congratulations on that. And obviously, we have a bit of role reversal in terms of poacher turned gamekeeper twice. And obviously, I'd like to congratulate one of the previous Cabinet members for their elevation to being the Vice Chair as well. Before we start on the report proper, can I just mention one thing? It would be completely inappropriate not to mention the hot weather outside, given that this is one of the hottest days of the year so far, and we should encourage everyone to drink lots of fluids, and by fluids I mean water, rather than just any fluid, and to seek shade wherever possible. Can I also thank the previous Cabinet members for their clear direction of travel, particularly on this subject of recommissioning of care homes. So the report in front of you seeks committee's input to both Cabinet decisions and the broad direction of travel relating to care home commissioning intentions, which includes fair pricing to residents, care homes and taxpayers. It also includes whether county should increase its active role in the market as a provider, and also looks at the point about maintaining and increasing the quality of our care home provision in Staffordshire for our residents. The paper itself looks at the strategic intent for long-term, taking into account the views of users, carers, family and care homes themselves, and is part of a consistent direction of travel on that. If you are happy, Chair, I would take the paper as read, and we're happy to open up for any questions.
Okay, open to Councillor Atkins.
I was interested to see the huge difference of the net present value between Tamworth and Lichfield. It just seems remarkable. I mean, it says it's down to market pressures. Could you elaborate on that? It just seems to be a huge difference. That's my first question. If the decision is made by the Cabinet not to pursue the development of new nursing homes, what sort of scale of resources have been used to develop these nursing homes to date? So and the other question I wanted to ask, which refers to paragraph 34, what percentage of the sector has operating costs which are not competitive and therefore not applicable to county council placements?
Thank you, Chair. So just on the first one, so the net present value analysis uses a range of variables, and I'll just go through them. So first of all, it's dependent on the number of beds, so we've used an assumption of 80 beds for these 2 care homes. Secondly, there's an assumption of occupancy rate, and we've used an occupancy rate of 95%, and then we've gone up to 100 and down to 80 for sensitivity analysis. It uses an assumption about capital cost, so how much it costs to build it, and so far we've used a figure of 24 million as an estimate, with a lower figure of 20 and an upper figure of 32. We do need greater precision about those estimates before we're able to make a final Cabinet decision. It then uses a figure of the operating cost when the homes are open, so that's based on how many staff it needs, the cost of consumables and all of the costs that it takes to run a care home. So all of those figures are the same for Lichfield and for Tamworth. The thing that's different is the market comparator cost, because what we're trying to compare is how much would it cost the council to place people in these homes compared to how much would it cost to place in the market. And at the to get the market comparator cost, we can only look at historic trends. That's all the data that we've got. So if you look at the historic trend of prices in Tamworth, they've been going up very steeply over the last few years. Lichfield has also been going up, but not quite to the same extent. Now, one of the challenges with this is that it's very difficult to predict what the market comparator cost might be, even in a few years' time, let alone over the 30-year operating lifetime of these 2 care homes were they to be built. So that puts quite a lot of uncertainty in the analysis. If you look at the NPV, if you assume that the prices in Lichfield and Tamworth keep going up as they have done over the last few years, it makes the NPV look strongly positive. On the other hand, if you assume that the prices in Lichfield and Tamworth level out at this point and only go up in line with inflation, it makes the NPV look much less favourable. Now, exactly what prices will do over the next few years, all we can do is estimate within a range of plausible assumptions. We can't put any precision on it. So we'll have to do the best modelling we can, but then make sure that Cabinet understand the limitations of that and the kind of range of estimates of NPV to take that into account.
Okay, thank you.
Chair, if I can come in as well. So I think there are 4 things for my money on this. The first one is we can either wait and see how the market develops, and in which case the county will always, as a large user of care homes, we can wait and see what happens. But then that leaves us very reliant on the turbulent marketplace, which is where we are today. Second of all, because it's a new build, then you're looking at a long-term business model, potentially 30 years plus. And in reality, it's a very small percentage of the total market provision. And I think from a principal point of view, because it's a build, it's going to take time to get it out of the ground and operational, and it's about knowing when to intervene in the market because the market isn't working as effectively as it could do, and creating and balancing that supply and demand. Thank you.
Should we go to the other questions? So I think the final one was about the number of care home placements that are outside the range.
Outside your price range, effectively.
So at the moment, we don't have a price range. So at the moment, the price is set at the point someone needs care. And that's one of our problems, is that the price is going up pretty quickly. If the price of care homes continues to go up over the next 3 years, as it has done over the last few years, then it would exceed gross budget by about 25 million by 2027-28. So we do need to do something about that. So one of the things we're considering is whether we do set a price range. If we did that, there are a range of options available to us. One of the ones we're exploring is that for older people, there's an industry standard model created by a company called Lang & Buisson, and they set kind of cost models for the various types of care for older people. If you look at the Lang & Buisson range, in the 12 months to the end of June 2024, about 37% of all older people placements and 45% of new placements exceeded the top end of that range.
Come back, Charlotte.
The third question was about the resources which the County Council has put into developing these new nursing homes, and if the Cabinet, well, in areas, whichever decision is made by the Cabinet, what sort of investment in resources has the County Council put into developing the outline for these care homes?
Thus far, it's been offers a time, essentially, so nothing of any note in terms of financial resource. There is a sale of land at Solway Close in the pipeline, so it's a sale from Tamworth Borough Council to the County Council for the Tamworth home. Again, if that were not to proceed, then we would resell the land, and the expectation is that we would cover that cost. If the decision in September is to continue to work up these homes, I think there would be a financial commitment for some expert independent advice to help us with the cost modelling and for all of the workup of the capital costs and the planning permission and all those sorts of things.
Councillor John Jones.
Thank you, Chair. Thank you. Yeah, thank you. Thank you, Councillor, for the report. It says, I'm just a bit concerned about the, it says, well, roughly 1 in 5 of both residential homes and nursing homes are not rated outstanding or good. So it's 1 in 5. So those figures are pretty poor, don't you think? And I know it goes on to say that we're expecting this to improve. And I just wonder what the issues were, mainly, and how are we ensuring that they are being improved. And also, it might be me, because I'm a bit dim, it says details at Appendix 1, Figure 1. I can't find an Appendix 1 or a Figure 1.
Yes, first of all, so apologies, the appendices seem to be missing, so we'll circulate those to the committee afterwards.
It's usually me, but it's obviously not today, thank you.
So the 80% quality, to an extent, it depends whether your glass is half full or half empty. So, you know, having 4 in 5 that are good or outstanding, I think, compared to national averages, is pretty reasonable. We do have a very active quality monitoring and assurance function in Staffordshire. So we do think we have a pretty good insight into the quality of homes. One of the downsides of that is because we're doing many more visits than your average local authority, we pick up more problems. When we find problems, we have a duty to report those to the Care Quality Commission, who may come in, and as a result of that, a home may be downgraded from good to requires improvement. For all of the homes that requires improvement, we work with them to make sure they have a plan to improve, and we do oversee the work and the actions they need to take in order to improve. We do think that some of the homes that are officially rated as requires improvement have now improved and are better, and were the CQC to inspect them tomorrow, they would come out as good. The rate limiting step in that is the ability of the Care Quality Commission to actually inspect them. You might have seen on the news that their capacity has been quite limited over the last few years, and inspections have been delayed, which means it's quite difficult now for a care home to come back from requires improvement back up to good.
If a care home, if we identify a care home as needing improvement and we report to CQC, do we then inspect again more rigorously? Do we go back more often and until we're happy?
I don't think it's so much about us also inspecting, but I think it is about working with that home to make sure that they've got an action plan that addresses any concerns the CQC might have flagged up, and also to make sure that those actions have been completed and that there is a clear continuous improvement process that's embedded.
Okay. So if, just one more there, Chair, for me. So typically what sort of issues are we talking about? I can probably understand what the issues might be in a nursing home, but in a residential home, what type of things are we talking about? Is it food? Is it cleanliness? Is it occupational density, you know, sharing rooms, that type of thing? What type of things typically are we talking about?
Could be a whole range of things, from the quality of the environment, you know, whether it's appropriately adapted, whether it's clean, could be about the quality of the food or the amenities, could be concerns about how well staff are trained, could be concerns about medication and whether there have been errors in giving pills and tablets to residents. So there's a whole range of domains that the CQC look at. And any one of those, if the home isn't meeting requires standards, could result in a judgment that gives an overall rating of requires improvement.
Just what this button doesn't work. Do we look at staff to resident ratios as well? Because that seems, I used to go in and out of care homes quite a lot in my previous life, and a lot of the time it's lack of staff is a major issue, which causes a lot of the problems.
Yes, so when we're working with care homes, that's one of the things that we'll look at. So both the staff to resident ratio, but also the quality of staff as well. So the kind of culture and values and training and all those sorts of things.
Thank you very much. Thank you, Chair.
Councillor Pert, you want to come in?
Yes, please. Just one other thing to add is that I understand from the team who look at the improvement plans within care homes that the CQC are very much aware of the activity that we undertake and the framework of work that we do to help support those care homes improve, and that they are assured.
Janice Sylvester-Hull.
Yeah, thank you, Chair. I won't revisit the questions that have already been asked on the pricing and the equity and some of the other aspects that have been done. My questions in particular. In terms of the timely access, we've got 88% being recorded in June 24, and I just thought if you could give us some context, it may well have been in the appendices or not, as to those that aren't in that category, how long it is taking for those to get the access that they require. The blocking of the booked beds, 96% at the moment. Is it ever likely to be 100%? I would have thought for cost efficiency we'd want it to be as maximum as possible, but I can imagine that notwithstanding some of the answers to the access and things like that, how that would work, and especially in future if we're looking to extend the provision of that, that could be more precious beds that seem to be available but not occupied. And then my final question on the improvements as to whether we've got clear deadlines on those. So things such as the electronic system that's referred to, that if you can just give us a bit of context on that one as well. Is that something that's an internal system only, or is there any sort of front-facing element that is also apparent to that, so to service users, for example, and for accessibility? So two sort of questions on that last one, which is regards to the deadlines, but also specifically on the electronic systems and the impact on the users for those. Thank you.
Thank you, Chair. I'll perhaps cover the access, and then Helen, can you do the block book beds and the systems? So in terms of access, I think we are pretty pleased at the moment with the speed of access to care home placements. It's one of the things I think we do really well. Where people do wait longer than the timeline, it's typically because either their needs are very complex and they require some kind of specialist care, or sometimes because the person and their family just want a bit longer to make up their mind. It's a big decision going into a care home. Some people want it done quickly, others prefer to take a bit of time about it, think very carefully about it, so they will take longer. So we go at the speed of the individual where we can. Helen, do you want to cover the block book beds question and the systems?
Yeah, so on block book beds, I think we try to get it as high as possible in terms of the use. I don't think you'll ever get 100% because there's always, because we pay the homes regardless of whether the bed's occupied or not, there are always going to be a few days between one person moving out of that bed and someone moving in, and that's counted as unused days, but it's days that the home is probably re-preparing the room, dealing with any maintenance, cleaning. Also, as Richard said, what we like to do is enable families to have the opportunity to go and visit. So we might have identified a block book bed for placement for somebody, but the family might need a few days to actually go, have a look at the home, see what they think, and have a view. Or sometimes it's just a case of getting in touch with family, because unfortunately 9 times out of 10 the person themselves isn't in a position to be able to give the informed consent, so we have to work with people who've got the legal power of attorney to represent those individuals. 96% I'm reasonably comfortable with. Like you said, we're always striving to improve, and as we bring more block book beds on stream, we want to be able to offer people more choice. So in some areas and for some categories of care, particularly for older people might have the choice of 3 or 4 different block book beds in different homes for them to have a look at. That inevitably will lead to a little bit more time, particularly because people tend to want to do that at weekends, as opposed because people are busy, they've got lives and jobs of their own as well. But we are always striving to increase that, but I don't think it'll ever be 100%. The electronic system, that was some feedback we got from providers. So we had a number of sessions with providers at the beginning of the year. This is the system that our brokerage team use to source placements. And I think it's, you know, it's fair to describe it as quite clunky. It's a procurement system that's web-based, whereas what we're trying to do is we'll be looking at moving to a procurement system for sourcing care home placements that is actually more bespoke, and it's the system that we currently use for sourcing home care packages, and it's far more responsive. It's made for this job, so it's a lot easier, whereas providers have told us the current system that they use for the care home beds is really quite difficult for them to navigate around. It's quite a lot, you know, the usual thing is you try and say 3 steps on anything that you're trying to do. Well, I think this system's got 33 steps from what they were saying. So, but at the moment there isn't any user interface, but what we are trying to do is develop a user interface that means that people can block book themselves. So for people that have rolling respite, rather than having to go through a brokerage team or a social worker to then go to the brokerage team, that actually if they've already got their assessment and their personal budget agreed and they know the dates that they're going away, that actually they could block book their respite placement with the care home directly. And so that's one of our ambitions for the new system when we'll roll that one out.
Yeah, thank you for that comprehensive reply. So the other part to that was whether there were clear deadlines to make sure that any improvements to the clunky system were going to be available from. And if I could just go back to the timely access question as well. So for those that are exceeding the dates that or the times that we've got in here, have you got any indication of how long that some of those others may be actually taking for whatever reason, as you've already explained?
haven't got that information at the moment, but I will find it, dealing with your last point first. But we can get a summary of that. What we will say is that no one is at risk. So we ensure, so if someone is remaining at home, they remain at home with additional care, support, or they may be in respite, and then moving to a permanent placement from a respite placement. But we can certainly get some information on those people and make it available. In terms of the new system procurement, we have put together a timeline and a process, so sort of a project plan, because we love a project plan, in place to be able to do it. And I think the ambition is that we will have the new system up and running by April, May next year. So, but we do have to procure it, because obviously the amount of money means that you can't just award it to somebody else. So we will be linking in and procuring that system.
Okay, thank you. Councillor Julia Jessel.
Thank you very much, Chairman. In quite an interesting position, as I some time ago got Cabinet to rethink the original plans for building additional nursing home capacity particularly. And I do hope this project does proceed, because and perhaps the report misses out some of the key points. We have 2 existing care homes in Meadowrith and Bracken that are time expired. They're on sites that have limited ability, either through the design of the building or the constraints of the site, to expand them and develop them. So actually developing 2 new homes was a way of actually addressing the fact we've got 2 existing homes that Nexus operate as care homes that will need replacement, but actually it affords the opportunity to increase the capacity and have a nursing home element as well. This enables the authority to disrupt the market, because the market for nursing home care particularly, there's high demand, not sufficient supply, and I think through the normal demographics of the population, there's more people living longer. I can't foresee within the next few decades nursing home capacity reducing significantly. So on that basis, I think it is important that we really do seriously consider these as options. Who operates them is another matter entirely. Who actually undertakes the design and build, and as Richard well knows, there are companies nationally who design and build nursing homes. They are all on a fairly similar footprint, and if we're looking about getting buildings built quickly and economically, I would seriously consider or ask that that is a consideration, rather than the authority go down using our own expertise. I think there is a real opportunity, because if a decision is taken, any delays to build add to the costs, and I think there are opportunities to have a slightly different approach. So I would like to see that included in considerations. The other thing that I would seek some assurance on is one of the things in terms of improving quality and efficiency in operating nursing and care homes is the increasing use of technology. And I know it was one thing that was thought of, that actually this would enable the authority to act as a bit of a leading light locally, to utilise modern technology to improve the quality of care of residents. The care home sector, I'm steering against too many generalisations, but some still operate on fairly old-fashioned lines. You'll find that the computer system is in a cupboard somewhere and staff almost have to queue up to use it. I think there's a real opportunity for us to be able to be a leader in how we can utilise technology. Richard and myself and some members of staff went to visit the BT site just to see the art of the possible, and there's some really good technology. So I think I'd seek assurance that any design and therefore costs include incorporating technology. The other thing is that I'm very keen on, and again seek assurance, that the costings do include having what I would call a sinking fund. As we all know, any premises, whether it's care home, nursing home, hotels or whatever, do require regular maintenance and upgrading. Commercially, I think it's every 5 years, they do need a significant facelift, because once they start to look tired, people go elsewhere. And we can't afford to do that. It is a competitive market. And one thing that local authorities are not particularly good at is ensuring that there is the finance there to ensure those homes are kept in good condition. So can I seek assurances on those two things, that when a report comes to Cabinet in September, that those are included in the costings, because I think it is very important. Thank you.
Thank you. Thank you, Councillor Jessel, for your questions. It felt like you were writing my homework as well as looking to mark my homework. So I appreciate those inputs, though. You're absolutely right that the existing capacity that we have within those two markets is time expired. So there is a need to do something, but there isn't a need to do something at any cost. And I think that really sort of hits your second point, which relates to the external experience in design and build. And you're absolutely right, and that is conversations I've already had, because the business model only works if we get the right capital cost input and the right operational cost input. And if we aren't careful, we'll design stuff that we don't ever need. I always think there's a need for a sort of a black box room. You know, there's always a piece in any building that actually you need a bit of extra space that you've never thought about, because that's just the way operational requirements tend to run. But it is important to make sure this is cost effective for our residents, but also is a place that is of high quality in terms of the care provided, and is a place that residents want to go to. And it's a really difficult balancing job, but we certainly can't be using public money in the wrong way. I think the other thing in terms of assurance, in terms of technology, we don't know, given the speed of technological change. You look at how fast AI, artificial intelligence, is moving at this moment in time. We don't know what is going to be in the art of the possible in 5 years' time, let alone in 10 years' time, let alone in the 30 years business life. So you're absolutely right. We need to make sure that we are using the most up-to-date use of technology that we can. But I think the thing that you didn't touch on, but we need to also work on, is making sure that increasingly young people and the staff see the important role in carers, or being a carer. And for me, this is another opportunity for us to demonstrate the importance of young people coming in to care as a career. And certainly the strategy that we've got in terms of staff underpins that as well. But otherwise, your points are well made. And we will look, when we come to bring the business plan and the business case for the project, which it's only a creation of the business, an agreement to continue to create the business case in September. So it won't be a finalised article in September. So we will continue to do that and make sure there is a sinking fund within it. Thank you.
For those comments. Picking up on your last point, we're asked to submit our comments today, which actually is quite difficult because we haven't seen sight of the business case, so we don't know what's included, we don't know what the recommendations would be. Can I, through you, Chairman, ask if there would be an opportunity for either this committee or perhaps a small subgroup to actually have some oversight of that before it goes to Cabinet, because I find it, we're asked to submit comments on something that we don't actually have the detail of. And that's a question I would wish to ask. Thank you.
If I can come back. Absolutely. So our intention is to fully brief this committee and including local members, because I think local members' input on the ground is also quite important to this. This is more about the direction of travel. You know, is committee comfortable with the direction of travel? We'll then get to the next level in terms of the business case. I'm more than happy to share that with either a subset or with committee, but also local members. And
in terms of, obviously, just to clarify, in terms of the business case, I'm quite liking the idea of a working group to overview that, because I think it's important that we're working with rather than against. And it's in a sense, it's not to say there's a business case, but we want to make sure it works, and we need to be quite sure we're looking at that. So I'm more than happy that we can look at that at a better, so we'll talk about that.
Chair, I think that as we continue to evolve, we'll probably get to a point where Q4 this year, early next year, we will have the business case. So that's probably, or evolving the business case. So that's probably the most appropriate timing, if that helps.
Thank you. Any more Councillor Jessop? No. Councillor Norman.
I was watching Councillor Jessel to see which button it was to press. My first question is on 9A, I'm afraid, and I'll just read out the sentence there. Quality of care homes in Staffordshire, as measured by Care Quality Commission, Staffordshire average ratings are just below the national average, and this may be a consequence of the Council's active quality improvement function, which identifies more issues than other local authorities. I'll just read that out in case somebody's watching this meeting. My question is this: isn't it a bit of I can't think of the word is less than dangerous, but isn't it a little bit dangerous to start complaining about the inspector, really? I mean, all schools might have a different view about Ofsted if they don't get a good inspection rating, and certainly all restaurants deny what the food hygiene rating says if they get less than 3 stars. So I just wonder if it's, a little bit dangerous, a little bit awkward questioning that. First of all, it's a political question, but the officer can answer it, of course.
So I don't think there's any implicit complaint about the CQC's judgment. I think what's some care providers at the moment have become a bit frustrated by is the pace at which the CQC can inspect. So there are 2 problems. First of all, for new care companies, when they're just getting set up, getting a CQC inspection and registration in order to start their business. I think that's become an issue. And the other one which is relevant here is that where a care provider, be it a care home or any other, has been rated as requires improvement, and they've actually made all best endeavours and done a lot of work to improve their quality, and they think they've done a really good job. And what they want is a re-inspection in order to give them a chance to for that to be reflected officially in a good rating. And they're finding that they can't get that re-inspection because of the CQC's capacity to be able to re-inspect. So I think that's one of their frustrations, and I think it's also one of ours, because it just feels a little bit unfair that where care homes have put an awful lot of work in to be able to improve, they're still living with a requires improvement rating.
If I come back on that particular subject, how does that differ from food hygiene ratings or Ofsted, whereby, at the time of the inspection, 6 of the homes in Lichfield District required improvement or more. So, okay, there's a delay, but at that particular time, I'm assuming you'd accept, if you're answering these political questions, that these inspections were correct.
So any inspection by any regulator is only a snapshot in time. So you're quite right that the CQC could visit today and pronounce a care provider as good or outstanding, and then they have a change of management, and in a month's time there requires improvement or inadequate, and that will not be reflected in their rating. It is just that over the last couple of years, the CQC has experienced some quite significant difficulties with its capacity, which has constrained its ability to inspect the market. So I think those are well publicised. Care providers have become a bit frustrated by that, and it also affects the way that we relate with them as well.
Can I just bring in Councillor Pett?
Thank you, Chair. I just wanted to pick up 2 points. One is, I'm sure members will have seen at the weekend extensive reporting of Wes Streeting, the Secretary of Health, his assessment in terms of the CQC, and it was certainly well trailed through the weekend's media. And I think that really does support what Dr. Harling is talking about. But I just want to flip the conversation to the opposite side. I was lucky to be invited and attended the Dignity and Care Awards. And actually, yes, we need to bring those care homes that are at any level up the scale, but at the same stage, we need to celebrate all that is great and best practice within the existing care homes within Staffordshire, because actually, many of them, as is demonstrated by the numbers, do a fantastic job for our residents.
Councillor Norman.
Well, just finally on this is the Scrutiny Committee, so obviously I'm concentrating on the problems that we have rather than the praising them. This is always the problem with scrutiny, but that's what I think that's our role there. Are we saying then, is the County Council saying that CQC inspections are a bit worthless pretty well? Because I understand it was the hospitals that had the issue with CQC, but it doesn't matter. If CQC is no good, presumably we can have the same view about Ofsted, surely.
Chair, I don't think anyone's suggesting that CQC is of no good.
Yeah, Councillor Norman, I think we mustn't stray into the criticisms in terms of the QCC. I think what we need to do is just address, obviously, what they say is that we can move in. And I think, Dr. Richard Harling, it is a snapshot in time. That's their inspection at that point, and we then have to respond to it.
Yeah, can I just add as well, I think we're at risk of deviating quite significantly from the topic of this paper, which is about the commissioning for care homes and development of additional capacity. I think if we're wanting to scrutinise inspections and the quality of care, that needs to be the subject of a separate report. But this is specifically about commissioning additional capacity and the progress of those proposals. So I would, I think the topics outside the core topic of this paper, and if members do feel that they want to look at the quality of care home provision, that needs to be a subject of a separate report. Thank you.
There is a separate subject matter. Councillor Norman, I appreciate what you're saying. Sorry. So in terms of we can come to that's it. Moving on.
Well, obviously the county started it by that 29A paragraph, but on, 9A. 9A, though, there's a need to replace ageing capacity at Meadowworth Care Home in Tamworth and Bracken House Care Home in Lichfield. It's just, as you all know, Richard, you know, Chair, that the Bracken House is not in Lichfield, it's in Burntwood. I just wondered, and it's a little bit awkward, if it's Tamworth Borough, Lichfield District every time, that would be helpful, and I won't say misleading, but it would be helpful. And the other one is on 30, I think it is, where it refers to Burntwood North. Well, it did make the case in Burntwood for naming the new health centre Burntwood West, so I'll just put that down on record there. But do we know what's happening with that? Because that involves the care homes as well. The building has got to come down and the land cleared by September. I'm not aware that an application has come in for the health centre which was cancelled in 2010. and is supposed to open in 2025, 15 years later. So are we able to get an update on that? Because that involves the care homes, the capacity part of the application. But I'm not aware that an application has gone in yet. Thank you, Chair.
I think that's something we would consider. Would that be a date that you may have, or something that we would need to come back on?
Chair, there is, just in terms of the last point, the Burntwood primary care practice, it's designed to be a primary care practice, not specifically just doctors, so it will have a whole suite of services, including podiatry and dietitians, and potentially will be in conjunction with other partners in terms of health. That is a separate strand of activity. There isn't a planning application ready to go at this moment in time, but the project is being worked on. Happy to share dates with you when we would seek committee's input or whatever level of input, but obviously we would also want to engage with local members as well on that specific development. I'm sure we'll get into the dichotomy that everyone will want everything a bit like a sweet shop, and will be constrained by both size of space available and budget as well, no doubt.
Thank you, Councillor Pert.
Thank Councillor Pert for that, but also thank him. This might be a bit weird, but to thank you for using the word dichotomy, because that used to be a fashionable word years ago. Now it's existential and a threat. So I'm actually going to do a tweet just on the English. So it's great to hear it. I'll give you a mention, actually.
Thank you, Councillor Norman. Councillor Atkins, and I would like to move on after this. Thank you.
Thank you. I just wanted to, Councillor Jessup talked about technology and the role it had to play in quality of care, but another area which obviously impacts on quality of care, in the workforce strategy, it talks about the vacancy rate for registered nurses in care homes had gone up from 9% to 16% in 21-22. Do we have an update on that figure? Because clearly, if we don't have registered nurses available, then that will impact on our capacity to extend provision. And, you know, the fact also that turnover of registered nurses increased from 47% to 55.5% in the same period. And it seems to me that, okay, that this is care homes as opposed to nursing homes, but having said that, you would want to have registered nurses available in those care settings if we're going to have good quality of care. So do we have an update on that? Is that going to be a constraining factor in terms of expanding the sector?
Through you, Chair. Thank you for that question, Councillor Atkins. Clearly the role of the workforce strategy is to do some of the bit I described earlier, which is to demonstrate to lots of people that actually care is a really valuable career and should be a career pathway between both the NHS and caring. I think the figures that you refer to, 9% jumping to 16%, there was a COVID impact. My understanding is that the numbers have dropped back in terms of vacancy rates, specifically on those roles. I can't give you a direct answer at this moment in time, but I thought they'd drop back. But I would say that there is a joint strategy with the ICB, the Integrated Care Board, in terms of workforce. It's a social care and NHS workforce strategy piece. And I think that's coming to committee later in the year. I want to suggest maybe it's October or November. So either we can provide you with immediate figures now, which potentially might be slightly out of context, or alternatively we will be back. That sounds like an Arnold Schwarzenegger. We will look to be back in committee later in the year.
I'm happy to wait until later in the year, but it just seems to me very worrying. I appreciate there would be a COVID impact, but that is still a massive increase, and the turnover rate is significant. So I think, yeah, if that could be addressed in the paper that comes back in October, November, that would be important.
Thank you, Councillor Atkins. And I confirm that will be October, so we'll make sure that that's the case. I think that's been a very useful debate. going forward. I think the key summary is that I think the committee to consider how to scrutinise the development of the business case. I think that is quite clear that it would be involved. I think there was assurances regards technology and the developing of a design and build. So those items to ensure that we capitulate. And other than that, I think thank you for the presentations. Councillor Pert, Richard Harding and Alan, do appreciate it. So if we can now move on. Swapping places, we go to item 5, and we've got 5A, maternity and neonatal services update. Alan Slater, and have we got Gina Jill? No? Is she coming? If that helps you, I don't mind that. I think in terms of questioning, I think we might, if we're not careful though, we might lose out on 5A and concentrate on 5B. But if that's how you wish to proceed, I don't see any reason why not.
Okay, I'll start with the maternity overview paper, if I may, and I'll just give an overview of this paper for maternity and neonatal services. So I'll start with the post-Ockenden visits. We've had, we last came to the Oversight and Scrutiny Committee in November, and since then we've had 3 positive visits over 23-24, which includes the national team and the regional team. And they have, as I said, you know, were really positive, and the trust were commended for the work that they were doing at UH&M. It's important to note that the NUH Ockenden early recommendations have been benchmarked against. These actions are being taken forward through our local maternity and neonatal system equity and equality plan for 24-25. And since January 24, we've really strengthened our governance with the neighbouring integrated care systems. We attend the local maternity and neonatal boards for Derby and Derbyshire and the Black Country, and their quality and safety and oversight. As we know, for South Staffordshire, we have a really close working relationship with Derby and Derbyshire ICB, you know, to ensure we work closely around those women for the Staffordshire area. In terms of the strategy for maternity services, we continue oversight of Year 2 implementation of the single delivery plan for maternity and neonates, and progress against each theme continues, which we monitor monthly. In terms of monitoring and regulation, the UH&M System Maternity and Assurance Group was stepped down in April 24. This was following a meeting with the national team, the regional team, the GMC and the MMC, and the Trust was commended for all the work they had done, and the ICB. They've been on a really huge improvement journey. The ICB continue that oversight through a perinatal quality oversight pack, and we monitor those metrics monthly. UHDB continue support from the NHSE maternity support programme, with further support from the regional team around quality improvement. UHDB progress has been made with all actions, and they're either completed or on track, and now the focus is on about embedding those actions. We also, as a local maternity and neonatal system, have benchmarked against the all-parliamentary group birth trauma inquiry report, and we are developing an improvement plan for that work. In terms of recruitment for maternity and neonatal services, in terms of midwifery, UHM, UHDB and RWT have reported positive recruitment, and they should all be fully established by November 24. It's important to note for UHDB, they have recruited 46 midwives, some of those newly qualified and international midwives, so they're on a preceptorship programme currently and will not be included in the full establishment numbers. In terms of medical and neonatal workforce, UHM report the medical workforce should be fully established by November 24. UHDB vacancies remain for the medical staffing. There are mitigations in place, then working closely with the East Midlands Healthcare workforce and the Royal College of Obstetricians and Gynecologists to increase that workforce. And I'll focus on, the last point I'd like to focus on is our neonatal deaths. So in Staffordshire and Stoke-on-Trent, across the ICB, we remain above the national average for our neonatal deaths. And actually, as an ICB, we remain the third highest across the region. We have to take into account those multifaceted aspects in terms of deprivation and ethnicity. And it's important to note that the Trust at UHDB and UHM review all those cases thoroughly through the perinatal mortality review tool, and that includes internal scrutiny, but also external scrutiny from external trusts and also the local maternity and neonatal systems. Both trusts have robust action plans in place, which are monitored through our Quality and Safety Oversight Forum. The crude data that we're seeing now in a current position is showing a decrease in our neonatal mortality, but we have to note this is crude data and it hasn't had that analysis, detailed analysis that the Embrace data provides, which is always 2 years behind. We also have the Trust both have a neonatal mortality group, but there is also an ICB infant mortality group, which really coordinates a system approach, and an improvement plan is being developed for 24-25. One of the key things is, as we know, that 75% of neonatal deaths and stillbirths are preterm births. So we have done there's a great deal of work around the preterm birth management and prevention in both trusts. There's also an ICB mortality group that is monitored, and there's a Midlands infant mortality group that we are part of. So I will take the paper as read and open up to any questions.
Councillor Janet Sylvester-Hall.
Yeah, just focusing on this particular part of the papers. When are you likely to see that impact being able to be reported? So you've mentioned that there's crude data at the moment with regards to the neonatal mortality, and I appreciate the detail there about it being above average, and equally the detail as to about what's being done to try and make sure that that figure is reducing. When do you think it's likely to be able to be reported with confidence that you can see the impact of that work that's being done? Would be my first and probably foremost question out of all of the information that you've given us so far.
I think, nationally we have to use the Embrace data. That's that detailed analysis. And I think, in 2024, it will be that data, but it will be 2 years ahead of that, so it will be published in 2026. So we continue to monitor the crude data, and we can see that decrease, but that detailed analysis that is provided nationally, it is always 2 years behind. So it's so important that we monitor both.
In the meantime, how do we assure pregnant women going into some of the places where, and again, we can see some of the detail where it might be more significant than other areas, that they're likely to have a successful full-term pregnancy, and that what we are trying to do is making sure that they are kept safe, and that there's also that shared responsibility as well, to make sure that they have that reassurance themselves?
So I think for that, like I say, we will monitor the neonatal mortality monthly. But in terms of the national programmes of work, we have the Saving Babies Lives Care Bundle, which is absolutely key for reducing our stillbirths and our early neonatal deaths. And that we focus, there's a review tool that we work with both trusts on to review the implementation. One of those is around reducing preterm births. So we focus on the management to make sure those extreme preterms are managed correctly. And we also monitor that those babies are being born in the right place to receive the right level of care. And those, for UHDB and for UHNM, they have some really complex, high complex cases. They have fetal medicine units, so it's making sure those babies are being born in a level 3 neonatal intensive care unit, and there's a clear plan of transfer of care. We also have the neonatal critical care review that we're monitoring that action plan to make sure they are embedded in practice. So, you know, there is a robust quality assurance forum that we monitor maternity and neonates on a monthly basis, which feeds into our boards.
Chair, we'll have a lot of more questions on the next part as well, and I think some of those are intrinsically linked actually, but if you want I'll give way to colleagues and then I'll come back later, I think.
Yeah, can I just support that as well, because UHNM are also attending our infant neonatal mortality group, because actually they have the women for a short period of time really in that woman's life, and we need healthy women becoming pregnant. So it really is great that they're engaging in the infant mortality groups that the ICB are leading on, and regional colleagues, we're feeding into that as well, because this is a national problem, because actually the solution doesn't sit just with the acute providers, it sits with us all.
Yes, thank you very much, and thank you for the report. I don't know whether it's me being particularly thick, but I didn't find it the easiest report to get to grips with. I've read it several times, and there's a lot of detail in there, but it doesn't flow, and that's just purely my observation. I've got a number of questions and comments, Chairman, if I may. This report is basically on UHNM and their part within the system in Staffordshire. As I've mentioned before, I think it's almost 50% of Staffordshire's patients are treated by trusts outside the boundary of Staffordshire. Can I ask if we will be receiving update reports from those other trusts, Good Hope, Walsall, etc., etc., because I think it is important as a Staffordshire organisation that we look to the care provided to residents in the whole of the county. A little bit of an aside and a bit of tongue-in-cheek. I notice on page 25 you refer to women giving birth, but also birthing people. I do have to say, the feedback I get from members of the public, it doesn't do the NHS any good. As far as I'm concerned, you're a woman if you give birth. You've got both references on one page. I'll just say that, a little bit tongue-in-cheek. There seems, I'm surprised you don't all become so overwhelmed by all the committees and all the reviews on this. I should think it's horrendous. And I think because of that, it's difficult for a layperson to actually get to grips with what's happening on the ground. And I've been a person in my working life, and I've worked in the NHS and in private industry, of always walking the floor, because actually talking to your users and your staff at the blunt end is the way you actually find out whether things are getting any better. I'd like to ask all of you, when was the last time you walked the floor? Because I should think you spend most of your life servicing endless committees and reports. I used to work in the NHS. I used to be chairman of the Health Authority in Gloucester, so I know what it was like. But if you're not careful, there's a disconnect between what you're trying to achieve, and don't get me wrong, there are real problems that you're getting to grips with, but actually the user's experience, your frontline staff experience, and sometimes you can only do that by actually walking the floor. That's one question. Following on from that, to me, a measurement of the benefits of the work that you're doing is perhaps in complaints and compliments, the user experience. There's no mention here, and I understand it's clinically read. I'm not criticising you, but I'm trying to look at this from a layperson's perspective. Local authorities are very much tasked with co-production, with making sure that users of services are actually involved in developing those services, not consulted on when you've already devised your plans, but actually involved in doing those plans. Can I ask whether any of that process has been involved in this? Because I think the user experience, women when they're having children throughout the whole process can feel quite vulnerable. And when you read, I've only read certain parts of the Ockenden report, some women's experience, their family's experience is quite frightening. And I think we would want to see some improvement in those metrics of the complaints, the compliments, which are really important, but also how those users are involved in improving these services. Apart from the perinatal and neonatal deaths, which are small in number, one can make a hell of a difference in percentages, and I do appreciate the fact that it does actually take time before all that is validated and you can use. I think those are my questions and comments. I appreciate it's a very emotive subject, because if it goes wrong, it's awful. I can't imagine. But I do think the NHS needs to cut through some of the bureaucracy, because if you're not careful, you'll be busy doing what you're doing, but actually, is it making any difference on the ground? Thank you, Chairman.
Okay, if you'd like to come in on that one.
Yeah, thank you. Thank you very much for your comments, and really helpful as well for us to reflect, especially on the report about it not flowing. That's really helpful to us for when we come back again in regards to that. Regarding South Staffordshire, we're very cognizant regarding our flows for our women, and that's why our ICB, LMNS, are in contact with the other ICBs and LMNSs to keep that. But you are right, we engage with them. I think we engage more with UHDB than perhaps we do with the RWT and Warsaw. They used to come to the QSOF meetings, but actually it's taking people away from their roles, so our staff now are going to their board meetings and their quality assurance meetings. So we'll take that on board as well regarding future reports. You talked about action plans, and that is a really, really good point. UHNM had over 28 action plans. You cannot monitor 28 action plans, they're falling over themselves. So in March, when the 3-year maternity and neonatal delivery plan came out, what we did was work with UHNM, and actually every action, every line out for every action was pinned onto that, because that is, we need one direction of travel, and all the actions were pinned on those themes. To make it one action plan rather than all of these action plans, and it kept people focused on where that action, what impact was that action impacting on the plan as a whole, because I think if you have too many action plans, it's who owns them, where are they going, what impact are they doing, so that really kept focus. Then you mentioned walking the floor. I've been on each one of those visits, and with our own team, with the regional team, with NHS England's chief midwifery officer, who is new into powers, and we walked the wards again, and to speak to the staff, and just to give you some insight, when I walked the floor in September, the staff morale probably wasn't as good as you'd expect it to be, although it was a really positive visit. But actually when I walked in March time, the staff were so different. They were so positive, their quality improvement, they oozed about what they'd done, what they'd implemented, what their plans for the future. They really had encompassed that quality improvement. The women that we spoke to were really positive as well. In Blossom Suite, I think they're making some changes in Blossom Suite, one of the ward areas. Now, that is going to be updated and changed. So they could have left those areas, but they've actually invested in murals on the walls to make sure that the women's experience, even though they've got to wait for a few months to make the improvements, they've invested in putting murals to make the environment as pleasant as it can be when you're birthing. And for the user experience, I'll hand over to Jenny to just update you on that one.
Thank you. Absolutely, maternity and neonatal voices is central to our work programme. So we have a maternity and neonatal voices partnership. So we have a chair and also maternity and neonatal voice champions across Staffordshire and Stoke-on-Trent. One of the key pieces of work that we're focusing on at the moment is working with the seldom heard groups across the system. And they often, the Maternity and Neonatal Voice Partnership, walk the patch as well and engage with women and families at UH&M and also at Queen's Hospital. So there's a real focus and we work really closely. They are independent, but we work really closely with our Maternity and Neonatal Voice Partnership. And naturally, you know, there'll be a key part of co-production in some of our quality improvement work around induction of labour, around triage, and they're actually, you know, they're absolutely central to that work. In terms of benefits, so I think for future paper we'll make sure we have a whole section on maternity and neonatal voice partnership work. In terms of benefits of working, absolutely we look at our complaints and compliments from feedback from women and families and incidents, so we can absolutely include that in future reports.
Could I just add one point as well? At board, we usually have a women's voice in the room, talk about their experience. Now that may be positive, that may not be as positive, and they're supported pre and post, obviously sharing their story in some cases. And if they don't feel able to do that, because it's quite overwhelming sometimes to come into our arenas, then one of the Maternity Voice Partnership champions will come along and present for them. But we start every board meeting to make sure when we enter that room, because as you've said, our lives are always busy and you're bouncing from one meeting to another. It's a time, it grounds you to actually, this is what we're here for, the women, the women's voice.
Councillor John Jones.
Yeah, thank you, Chair. Thank you for this. Thanks for coming along. My question, it might sound slightly naive, and it's not directly related to the report, but I just wondered, everything seems to be centred around Royal Stoke, or UHN North Staffs, whatever it is now, and the bigger hospitals. Staffordshire Moorlands is a vast geographical area. I just wondered if any consideration has ever been given, or could it be given, to running some prenatal services at places like Leek Hospital or Biddulph Health Centre. I suppose the assumption is that people that require maternity services are young and therefore mobile. But if you live in Ipstons or you live in Longner or somewhere like that, Stoke's a long way. And I just wondered if that could be if we could take that away and maybe it could be considered for the future. Because as far as I'm aware, there are no services like that. Things like scans and stuff like that. Thank you.
Thank you. I think that would be a good for us to take away and speak to our MNVP, to actually speak to the women in that area and do some focus work and get their voices heard.
I think it would be well appreciated because, as I say, the geography is quite substantial. Thank you.
Councillor Bernard Peters.
Thank you, Chair. Thank you for the report, colleagues. Could I just ask a few questions around paragraph 6, home birth services? My division is in Burton-on-Trent, so I've noted there that facilities have been reinstated at Queen's. Could you just give us an overview of how that's progressing? I noticed you started taking bookings in April 24, so it's not too far back in the past, but how many home births are you supporting? And are there any, I mean, high-risk pregnancies don't get anywhere near that, do they? And how do you communicate that message to the mums, that they won't be able to have a home birth?
So, as you said, so the home birth services were reinstated for taking early bookings in April. So there hasn't been any home births as yet in the community, because they've started to take bookings from April onwards, and they will start to come through in the autumn. And I think in terms of communication, if women are high risk, we have professional midwifery advocates, and their community midwifery lead would discuss the options. It is women's choice. It's important they're informed of the risk, but if they wish to deliver at home, that is discussed and a clear birth plan is put in place with the professional midwifery advocate and the lead midwife, and a plan would be put in place for women. So in terms of preparation, both trusts have been doing training for home births with the ambulance services. So there's been some fantastic work in terms of training. So ready to take on and start. I know staff are keen now to take on those home births, and that will start in the autumn. And we are monitoring that monthly to look at the numbers.
The very, very diverse community that we have in East Staffordshire, Burton-on-Trent, does that influence anything? I'm thinking that the language barrier shouldn't be a problem, but maybe cultural issues. Would more people whose English isn't their first language perhaps prefer to have a birth at home? Have you any experience around that? Because of the hesitancy of going into hospital?
I think it's personal choice. So I can't see specifically around ethnicity, but what's so important is that everyone has informed choice. So we make sure that we use interpreting services, so it's really clear around birth choices for all women.
Sorry, just to add to that again, earlier on, Jenny mentioned the EDI plan and the MNVP getting out to the women, just the hard to reach women, to actually speak to them, to get their voice. Again, it's about actually asking them, was that experience the experience you expected? Did you have the choices? So the birth plan, they do spend a lot of time, but actually you won't know until you ask the question. So that's an area that actually we're not as good at. We need to get out there and speak to those women and get their voices heard, to ask them exactly what you're asking.
No, that's on the list to address, is it?
Yeah.
Councillor Norman?
Thank you, Chair. This is not my area of expertise. I'm substituting for somebody who I think it is an area of expertise, on the basis that she's not here because of the latest baby, and they're doing well, I understand. But just a simple question on page 26, paragraph there, and also at the beginning, it says, the CQC identified some immediate areas for improvement and required rapid changes to some elements of practice to meet regulatory requirements. Did you find the CQC useful for you?
Thank you. Yes, the CQC were very useful, because actually there are areas that, especially the triage, where they knew improvements needed to be made, but actually the traction and the speed in which, the timeliness in which that changes needed to be made was actually not as speedy as you'd want them to be. The CQC coming in, actually those changes were expedited very, very quickly. So it was very positive. And picking up on Dr. Richard's Harling points earlier regarding the CQC, UH&M are also have made all those changes, made all those improvements, but actually it's waiting for the CQC to come back in, because they're absolutely wanting the CQC to come in. They've done a mock CQC and invited us as well to their mock CQC in that area, but obviously capacity within CQC means that perhaps they're not coming in the most timely way. But I just wanted to pick up on Dr. Richards-Harling point earlier. The CQC are under pressure to get out to revisit these areas.
Thank you. Just before I bring Councillor Jones back in, I'd got a question around that subject of the CQC regarding the inspection in August 2023, where it's obviously saying that the Queen's Hospital, Burton, was overall rated requires improvement. Now, anecdotally, I was aware that from friends and family that actually they were note of that and were choosing other hospitals to go and visit, have their babies there. And that's a bit of a concern, because that rather falls into actually what Councillor Jessel is saying, that they're going outside of Staffordshire for the treatment, but the birthing of their children, ensuring the quality and everything is there, that gives them the comfort of what I think, not personally experienced, but certainly through my wife's experience, very traumatic period. It isn't as easy as shelling peas as some may think. So I'm concerned of that improvement and the rate of improvement that can come from it. Have you got any comment to make on that?
Yeah, if I pick up firstly around the current position of Staffordshire women delivering at Queen's Hospital, Derby and Derbyshire ICB are the lead commissioners, so as I said, we work with them closely, and the current position is over 75% of women that deliver at Queen's Hospital are Staffordshire women. So we work with them closely to understand that. In terms of, could you repeat your last question? Sorry.
In terms of going outside of the Staffordshire for having their birth, how are we going to obviously improve the figures, that it means that those numbers are not going down to other areas, and are actually being in Staffordshire, and then obviously getting the Staffordshire figures that we recognise for our residents?
Thank you. So in terms of Staffordshire, working with Derby and Derbyshire ICB, the numbers haven't dropped, they remain at 75%. And we're also working with our maternity and neonatal voice partnership, going into Queen's and getting feedback from women. In terms of improvements at Queen's Hospital, the actions are progressing and are on track. But the key bit now is about embedding those actions. So there's intense scrutiny and support in place from the national team and also the regional team. And it is moving at pace.
And then I'll...
Yeah, thank you, Chair. This just a little light came on my head when you're having the discussion about home birth and a comment you made about training, liaising with the ambulance service. Now, ambulance staff are all trained in childbirth anyway, but my concern is I hope you're not expecting the ambulance service to cover this aspect of the job, because they can't cope with what they're doing already. And I just wondered, are there no plans to have sort of locally based midwives, the old sort of, I forget what the programme's called, Call the Midwife, that type of service, particularly in the rural areas, because, as I say, the ambulance service aren't going to cut it, certainly not at this time anyway.
So we do have locally based midwives, so they are based in the communities, providing antenatal, intrapartum care for the home births and postnatal care. So they lead on that home birth service. The ambulance service is involved when there's an emergency, and when women need to be transferred into the acute trusts. So they've been part of the training for those emergency skill drills. women would be classed in an emergency situation at home. They would be classed as category 1, so they would be fast tracked into the acute trust.
If I may, Chair, so in essence, really, nothing has changed. It was always like that. I was a paramedic for 12 years on an ambulance and in a car. That was ever thus. So you're not expecting them to take on any additional, which was my worry, because as I've said, that they are struggling at the moment to cope with what they've got. Okay, thank you for that. Thank you, Chair.
So if we can move on to then the 5B of the report, the intrapartum services previously provided at County Hospital, Stafford and Samuel Johnson Community Hospital, Lichfield. Who's presenting that? Helen?
Thank you. Good morning, everybody. So in your papers today, you've got quite a lengthy report that outlines some of the key evidence that we've taken into consideration through our options appraisal process. You'll be aware that we started this process prior to COVID, and we temporarily paused the review and picked it back up again in 2022. The paper outlines links to the previous paper in terms of maternity strategy, some of the national strategies that we need to be aligned with. It also talks through the engagement that we've had to date with women and families and key stakeholders across Staffordshire and Stoke-on-Trent. It outlines the proposal development process that we've undertaken, where we've gone from reviewing 5 proposals, and through a technical event we looked at a further 2 proposals last year, and then into further engagement. Within your papers, we also reference the West Midlands Clinical Senate independent review that we had undertaken earlier in the year. Part of that was going out to the sites with a team of clinicians that went to meet with the staff, interview some of the women and families that were utilising those services, but they scrutinised the evidence that we've submitted, and part of that evidence is within the document today. Our proposals going forward are the viable proposal that we have is to make permanent the temporary closure of the 2 birthing services. Now that means that there would be no change to the obstetric and midwifery services at either Queen's Hospital Burton or Royal Stoke, and no changes to the antenatal or postnatal care that women receive either at that unit or across the rest of Staffordshire and Stoke-on-Trent through the community services that Jenny's just talked through. We have within the paper outlined high-level communication and engagement plan, and we are proposing that to ensure that all women and families are able to participate further in the processes, that we undertake a 6-week consultation following the assurance and governance process that we need to adhere to for these processes. And it's for review today with committee as to whether you're happy with that 6-week public consultation proposal that we would include within our business case, and whether you would want to be, whether the committee would want to be consulted formally, or whether you would like us to come back at a later date in order to make that decision. Happy to take any questions.
Pick up on the consultation period as a starting point. I think 6 weeks on such an emotive subject possibly is narrowing the narrative that might come forward to make a proper decision. I would probably be looking at, from my point of view, would be looking at a 12-week consultation period. And that may then include that the boroughs and the districts that may be affected by this could actually have some input into the consultation, rather than just, keeping it obviously a Staffordshire-wide basis. That's what we're here for. But obviously this is also can be affecting local boroughs and districts, and I think it would give time for them within their cycle of scrutiny to assess the situation, whether they choose to have a call-in as such, but it would have the opportunity to get then the local view opposed to anything else. So I'm thinking more, you know, that you've got to broaden it to really assess the need, and that possibly, you know, 6 weeks. It is first few weeks, maybe we're looking at a holiday period and everything else, and then suddenly when everybody gets back to things, we're looking at a very short period of time, you know, in terms of assessing it. So that's my view on it. I'd like you to think about that as we go on, but I'd like to call in Councillor Janice Sylvester-Hall.
Thank you, Chair. I think on that particular note, on the consulting time, I would agree absolutely with the length of time, but also the style of the consultation as well, I think is really important so that we can get a fair and honest response from those pregnant and birthing women. And I will make clear use of both of those terms during this debate especially. The all-party parliamentary group, I think, highlighted the overall premise of how important it is that we listen to the women. So asking questions in a certain manner, I think, can give us the detail that we want openly and fairly. In other ways, can give us the absolute not. So I would be also very keen to see how we intend to go about having that consultation so it is a fair and honest reply. I think if I may, Chair, as well, just continue, so that's in support of those. The temptation for me here is that I focus on Lichfield City North because Samuel Johnson Hospital is obviously as part of my county division. However, my comments will apply equally to any of the other places that are being affected as well. I do have connections with a recently qualified midwife, and I have every respect for midwives and anybody who works in the service. It's great when things go well. When it doesn't, it's not. And that is not lost on me at all. One thing that I'd like to pick up on, first of all, is that we had, which is why I thought it was useful for you to do some of this together. Councillor Jones mentioned about extending services in some of those more difficult to reach, and we're looking at withdrawing services in this particular part, so there is a dichotomy, and equally a contradiction, I think, in some of the attention that's being put over. When we start looking at those out of county, it's got in the report that 23% of the births are outside of the local area. So based on the assumption that we've got 11,000 there, we're looking at 2,530 that are going out of where we've got direct reports for. I would really like to see more information on where those 2,530 are. How many of them are at Walsall? How many of them are at New Cross? How many of them are at Good Hope? In this particular case, and if I just take Samuel Johnson, it quotes 350 is the target, really, to be able to make it a viable service that's being offered. We may have an awful lot of those that are going elsewhere who would actually like to be locally using the services, because that's one of the factors that's quoted in terms of the area and the distance to travel. So I would like more information on that particular part, because we're also told that the digital systems lack connectivity in terms of the notes. So when they do go out of area, that's also something that is a significant factor in the quality of care that those birthing women are likely to get or not. So that's another question. Shall I keep going? Because I have a couple more. I can see you writing down some notes, but I'm more than happy to come back to some of these. I do get the safety part. You know, my question earlier on, my overriding question was about the safety of neonatal mortality. And then we're told that 83% of birthing women now are in a moderate to high risk. I'm still struggling to get my head around that 83%. So we know that if they want to go to freestanding midwifery birthing unit, they need to be low. 83% moderate to high, I'm just trying to understand the context of, so I think more detail on that would be very helpful. Chair, it might be useful for me to just stop at that point and get some information back, but if I could come back as well, please, and then I will gladly give way later.
Chair, Councillor Sylvester Hull, and I think very pertinent questions. So over to you, Helen.
Thank you. If I take, in terms of the length of the consultation and style of the consultation, we will take that back and we'll look at that. We recognise that through some of the engagement that we've undertaken over time due to COVID, some of that has been online. And we do want to get out and have those conversations, and we have a range of mechanisms that we would take into consideration, but happy to work with committee members to shape that consultation process. We also have members from the Maternity Voices partnership that will also help us to shape that consultation and engagement process. In terms of the activity of the women that are giving birth outside of Staffordshire, we do have that information and happy to share that with you outside of the committee so that you can see that. In terms of the paper that Jenny and Lynn presented previously, that information is reviewed through our governance process for each of those sites in terms of those patients that flow into Black Country, ICB, and into Derbyshire, and also in terms of the north of the patch in terms of Cheshire and other areas. In terms of the notes, the electronic notes that was picked up through the West Midlands Clinical Senate review. Since the review has taken place, University Hospitals of Derby and Burton have implemented BadgerNet, which is consistent with the notes from Black Country trusts, so there is that connectivity in terms of those notes, and maternity partners are also looking at just to make sure in terms of that connectivity for other areas that that women flow out to. And then in terms of the medium to high risk, it's related to the birth rate plus assessments. I'm going to ask Jenny to pick up that because that's a more technical one that she's better placed to answer.
Thank you. Yes, so this is picked up through the birth rate plus, but we also monitor this through our local maternity and neonatal system dashboards around those women that are booked on a consultant-led care pathway and those that are booked on a midwifery-led care pathway. As I mentioned earlier, in both units, we have some really high-risk complex women due to the fetal medicine unit that we've got, and also some of the maternal medicine cases. And, you know, it's important to note, in terms of deprivation, we have got in at UHM from Stoke-on-Trent, you know, it's the 13th highest rated area in terms of deprivation nationally. So there are some real high-risk cases, but what we are doing as a system through our quality and safety oversight is we are, the trusts are doing a deep dive audit to make sure women are on the correct pathway, so we can certainly feed back that information in our future paper.
If I can just come back on that point. So it might be my interpretation of this. So if it's 83% are in the moderate to high risk, does that mean only 17% of all those 11,000 birthing women would be eligible? I can see some vociferous nodding going on to the side of you. Would be able to use the birthing units? Okay.
Yes,
right.
that is correct. But I think what is important to note is pregnancy is a journey, isn't it? And someone can start at the beginning of their pregnancy as low risk and then become high risk, or become high risk at the start and then maybe step down. So it's important to note throughout that whole pregnancy journey that level of care is reviewed. So that's why we're doing this audit, to make sure that women are on the correct pathway.
Yeah, and I would support that entirely, and also obviously the voice of the woman and what
Absolutely.
they want to see happen as well, knowing that they're making an informed choice, obviously, of what they're intending to do. The other part that I just wanted to be clear of as well, so my district council colleague, who would normally be here, Councillor Young, who I was with yesterday, and her baby and her are absolutely gorgeous. If they're in a position now, you know, and speaking generally, and they decide, if as a mum in Lichfield, they go to Good Hope, that their entire notes would be available at the moment that they step through the doors at Good Hope, rather than Staffordshire, you know, within the county, or if they were to go to the Manor Hospital, for example, which I would consider a number of residents, depending on where they are geographically, would actually do that those notes would be with them on the Badgernet system now.
So in terms of digitally, then no, because unfortunately not all maternity trusts are on Badgernet. Great to see that UHDB has moved to Badgernet, but not all trusts are on the Badgernet system. So there is a variety of maternity information systems that are in use, and sadly they do not all talk to each other. So what would be clear is if a woman did go to Good Hope, her notes would be transferred with her, but they wouldn't have access to those digital notes.
See, for me, that's another reason, again, as to the nonsense of what we're suggesting here, when we've got 2,500 women that are going away out of this particular area to have their babies, not necessarily with the note supporting system, the locality and the distance, and yet we're still thinking that this is, you know, the most viable option is to make permanent the temporary closure of Samuel Johnson and also County. I'll leave that point for now, and if I can just pick up the next couple ones in there. In the report, I think the age of some of the data is questionable, especially when we look at profiling the demographics of the area. Again, speaking for the vicinity that I'm probably most familiar with, does it reflect what it used to be at that time? I don't think it does. We have had significant development, and I think the demographics and the profile of families in particular who are living in the wider Lichfield district would certainly, I would say, need to be reconsidered on that particular side. And then my final point for now, Chair, if we look at the fact that we've got quoted in the previous report full staffing as of this autumn and being anticipated, that we've got comments in the report later on that says that there is a connection to the environment at Samuel Johnson in particular. Can we just add some clarity on there are staff available to be able to man the unit, to serve the unit, and that they would like to be able to do that given the opportunity to do so? Is it just down to the numbers then that are wanting to actually go and to use, for example, Samuel Johnson in this particular case?
Yeah, if I just pick up the first bit. So in terms of the demographics, we'll go back and review those again, but recognise that some of the data, because the service has been temporarily closed, we are limited on some of the data that we can use, but we will make sure that that's reflected and reviewed again. In terms of the staff, there's two elements in terms of the staff available, which Jenny will pick up in a moment in terms of the workforce profile, because it's not just about having the numbers, it's about having the right profile, but it's also about the numbers of women that would want to use that service. And certainly prior to the temporary closure, there were campaigns to utilise these services and conversations with all women in terms of personalised care plans, etc. And the numbers weren't going to either Lichfield or to County Hospital. So we've got those numbers that we had prior to the temporary closure. Obviously, through the engagement, we can explore that a bit further.
yeah, just on that final point for now, Chair, I think that's why the consultation is so important. But if women are being told that it is unsafe for them to go to a freestanding birthing unit, then I don't think you would. But equally, making sure that 83% are in the right category that they need to be, and that we are making that decision with all of the information that we have available. Thank you.
I think on that point, in terms of saying women stating that it was unsafe, or that hasn't been the case. And I think, as Helen just said, it was down to numbers. The birth rate staffing assessment for UH&M, yes, they will be up to full midwifery establishment in November, but that doesn't account the freestanding midwifery birthing unit. It does at UHDB, and the birth rate assessment takes place annually, so it's reviewed. I think it's important to note, as I mentioned, at UHDB, though, they have appointed 46 midwives, but in terms of skill set, they are newly qualified midwives, and they are also, it's international recruitment as well. So what's absolutely key is, you know, that they have that 12 months of support. So, you know, that will take time.
Yeah, just from my own clarity again, though. So, if people are given the option, with the information that's been presented to them, to say you are in this particular risk category, this service is not available to you.
No, it's down to women's choice. So you can't say that this is not open to you. You would absolutely have an informed discussion, as I mentioned, with the professional midwifery advocate and the lead midwife, and a birth plan would be put in place. It's women's choice. So women have a choice to deliver where they wish, as long as they are informed of the risks.
Thank you very much. Councillor Gilligesso.
Thank you very much. Just explain and clarify for me, this 83% of births are high risk in Staffordshire. I mean, I understand, you know, women like myself are having children older. There's a problem of women still smoking in pregnancy, obesity as well. Within the public health arena, the local authority is well aware of those and the risks that there are. Is that 83% a percentage of the births in Staffordshire, or a percentage of all Staffordshire residents, i.e. there's 23% of them elsewhere? Because depending on how it's worked, it could be skewed. You've mentioned Stoke-on-Trent, high areas of deprivation. Perhaps the southern part of the county, parts of South Staffordshire, are not so, well, they're not deprived areas, although there are small pockets. But can you see, if it's not taken as the total number of Staffordshire births in or out of county, but only just those in county, then that 83% is skewed towards the higher risk population? That's my first question. The other question is, in terms of Lichfield and Stafford, they are within the county, with the exception, I think, Burton-on-Trent comes in it as well, and have been for a number of years the two areas of highest growth in population. If you go to both areas, the numbers of new houses that have been built over the last 10 years and continue to be built at a pace are in the thousands. So when you say you'll go back and look at the figures, the demographics, those demographics have been known for quite some time. The future development plans have really been known for quite some time. There's still hundreds of houses to be built. Is the demand built based on historic data, or actually up-to-date data and extrapolated? Because planning services, you've got a plan for the next 10 years. There's no point in planning for a service as it is now, and then it changes significantly in 2-3 years' time. So just understanding where your planning goes. The County Council, in terms of its education function, has quite a sophisticated way of calculating the number of primary and senior school places. I'm assuming you're doing the same, because in those two areas the population is changing quite significantly.
Yeah, so if I pick up the demographic and non-demographic profiling, so we've got national and local data that we take into consideration. So I won't go into all the technicalities here, but we do take into that population growth, the health inequalities, etc., the age profiles. So that is taken into consideration within planning services. Actually, through NHS England, there isn't any modelling that we have, so we need to work through with our providers in terms of the activity that's coming through, but then make adjustments in terms of those future projections, and that's linked into our wider strategic planning as well as within maternity. And then if I ask Jenny to pick up in terms of the birth rate plus data.
Thank you. Yes, so the birth rate plus data is trust level data. So it won't be based on Staffordshire women, and it does, the 83%. It's a national tool, and it is based on that trust acuity.
If I can come back on that, this is a theme that's becoming apparent with all NHS presentations. It did at the presentations we had at our last meeting, is that we're only getting part of the picture because of the NHS structures, and we're never getting the reports from other ICBs relative to actually what is a third of our population. And I would ask, Chairman, that we actually communicate our concerns that we're not able to fulfil our responsibility to the population of the whole of Staffordshire because of the ICB structures. It's not just your report, it's other reports where it's based on UH&M and we don't really know what's happening elsewhere. The thing that concerns me, and Janice has highlighted, that 83% does not reflect the risk profile of all women giving birth in Staffordshire, but only those that are linked to UH&M. In terms of my experience of NHS and in my former role as Cabinet Member for Health and Care, and in discussions with NHS colleagues and county colleagues, it became very apparent that the NHS is not very good at understanding local authorities' local plans and development plans. In terms of planning, the particular discussions we had were with primary care, and in particular two big estates, one in Burton, one in Lichfield, and there are provisions for schools, etc., within the local plan. There's provision for primary care, but the NHS hadn't caught up with that. Those were plans that were approved 10 years ago. So I do implore you, I know you operate with national frameworks and whatever, but actually the information from each local authority is readily available as to what the development plans are. You can actually quite quickly calculate what the growth population will be. The NHS has never been very good at it, and I think it's something that you really need to, in terms of your planning. If you don't know what your population growth is going to be, you're stepping in the dark. Thank you.
So just in terms of the data that we've got in terms of the growth, the birth rates, that is included within the paper, but we'll go back and we'll review that against the local development plans just for reassurance. In terms of within the paper, we do reference both UH&M's birth rate plus, but also UHDB, so University Hospitals of Derby and Burton, so their birth rate plus information is in there. We also have access to the information from our Black Country colleagues, so we will recognise that the flow of activity, whilst we've got to be careful that some of the paper that was presented before talks about the flow out and across the whole of Staffordshire and Stoke-on-Trent, we are mindful of some of the geographies that are affected by the proposal that we're putting forward, but we'll address that within the business case.
Thank you very much for that. That's really helpful. But I think that is a message that needs to go to our NHS colleagues, that when reports come to here, we need to know the picture for the whole of the county's population, not those served just by specific trusts, because, you know, we've got, as your map shows, patients going out to Telford, etc., etc. And I think it leaves us vulnerable to being able to make informed judgments in terms of anything relative to the NHS. So, as I say, Chairman, I would be most grateful if you could write to NHS colleagues expressing our concern that this is a repeated problem. Thank you.
Absolutely, and I think that is definitely an action that we need to take forward. And just before I bring in Councillor Norman, I think might have something to say. As from a county councillor and a district councillor, Lichfield, don't underestimate the build. This is the situation. We've got a plan that was to provide in Lichfield over 10,000 houses from 2008 to 29. Now, it is at the present minute at a fast rate because we're seeing it being built, but it's to assure what we know is that it's still not going to stop those speculative applications that come in that could that figure goes considerably high, and we then have a situation. So if you look at the demographics, yes, Lichfield is an elderly population, but actually it's you look at the houses that are being built will be attracting young families, and that's what you're looking at. So you'll have build for the retirement homes and so forth, where there's lots of them, we know, but also it's the houses that are also being built, and they are very much young families or prospective young families. Stafford alone is taking a big build. I think everybody is. East Staffordshire, if you go to Uttoxeter, you're seeing a complete, you know, that countryside now being developed. So I think the NHS got to look away from the national picture and look local to understand how we are developing and the needs to come from that. So it's a clear needs assessment for the local area rather than on a national basis, if I've understood my two colleagues quite clearly have articulated. Councillor Norman.
To be honest, because of what's been said before and yourself, just that, there's no need for me to add anything, so thank you for that. Thanks.
Okay. Councillor Sylvester.
Don't sound too enthusiastic, Chair.
I'm really enthusiastic.
Chair, if I may, just one thing that's just come into my mind is the role of Health Watch and getting the opinion of and the voice of women from that context. You mentioned maternity voices, and I just wondered if you could just give us a bit more information on that and how it might or might not fit in with Health Watch. But I would be keen to get a different, you know, the service user, let's say it, these birthing mothers' opinions as well, and I'd like to know what their input's been.
So the Maternity and Neonatal Voice Partnership, as I said, we have a chair and lead for that work, and we also have a number of champions across Staffordshire and Stoke-on-Trent, and that is building because we want to make sure we have champions in all local areas. In terms of Health Watch, they sit as part of our Maternity and Neonatal Voice Partnership Board. So all the feedback comes from Health Watch, and the Maternity and Neonatal Voices work closely with Health Watch together.
also in terms of planning any consultation going forward, Health Watch are key partners in terms of that, and from consultations that we've undertaken in the past, we have commissioned Support Staffordshire and linked in with Health Watch to enable those conversations with some of those groups that we can't get access to, you know, in terms of being NHS managers. So we use those community champions to go out there to have those conversations with those groups and individuals.
Well, thank you very much. I think there's obviously something that you've got to take away from this meeting. Clearly, we're looking at the consultation period. We'd like to consider it because it has an impact on a lot of the questions that have come out that really needs to be drawn out properly to evaluate a proper decision. And it's that assessing the needs and the future needs that are very close by. So certainly the committee, I will wish to obviously follow on from Councillor Jessel's recommendation. I believe committee would very much like me to take that forward in terms of the concerns representing Staffordshire residents in particular, so we can capitulate those. So I will confirm that. Would you committee like that to be the case? Because I think it's a sound proposal. So I'll get lots of nods from it. So I think that's important. Obviously, clarification on the demographics, because we can get skewed with one set that don't look at the an overall picture. Yes, we all know we're an ageing population, but that doesn't mean to say we're you know, a national birth rate may be down, but depending on your areas, it could be significantly different. So I think we've rounded off there quite well. Thanks again for those members that came in on that. Did you want to bring them back to committee? Yeah. So would we, as a committee, would we like to see our colleagues there come back to committee, or through perhaps a briefing paper? And if we feel that that briefing paper is not answering our questions, we call them in to a suitable slot within our work programme. Would members be quite happy with that way forward? Okay, got nods there, so thank you very much. Yes, sorry. Yeah.
Sorry, just on the paper that's coming back, can we absolutely be clear on, do you want an assurance paper and one about FMBU as well, update? Just for clarity, just making sure exactly what you want for the committee.
I think we're looking at the second part of the paper as clearly our concerns. And in a sense, a lot of those queries will actually, I think, in terms of your first paper, might just, you know, deal with those unanswered questions that we may have. So, yeah, based on the second part.
Thank you.
Okay. Moving on to thank you very much for your attendance, by the way. Sorry, I'm getting carried away with the next item. Okay, so item 6 on our agenda is the health impacts of Wally's Quarry landfill site at Silverdale in the Newcastle borough. I think for committee's information here, we really need to base our questions on those, as what the title of our the paper, of the health impacts. Newcastle Scrutiny obviously are looking at various issues around it more at depth, but as the body looking at the public health of our residents, want to make sure that we are questioning on the health impacts of what's happening there. So we have joining us online, we've got the UK HSA, we've got Katie Spence and Alec Dobney. Yep, I can see them, thank you very much. And we've got the Environment Agency, we've got Adam Lyons and Neil Newton.
Hello.
And Clive Wall. Yep, okay. And within the room we've got Dr. Richard Harling, Director of Public Health, Staffordshire. Richard, are you going to start introduction?
Very happy to, if you want me to, Chair.
If we could take your take on it. Yes, please.
So I think that the situation at Wally's Quarry has been quite well rehearsed, including at this committee, so I don't feel the need to retread over all the events of the last 3.5 years. I think there is growing concern about the potential impact on the health of residents. And I found it helpful to try and describe the health impact both in terms of direct and indirect effects, and also in terms of short and long-term effects. So if you can imagine a sort of 2x2 grid with 4 boxes in it. So first of all, you have the direct health effects in the short term. So again, these are well described. When hydrogen sulfide levels are high, local residents report stinging eyes, sore throat, nausea, headache, all symptoms that we'd expect from hydrogen sulfide exposure. And the intensity of symptoms tends to go up when levels of hydrogen sulfide are higher. Then you have the potential direct long-term health effects. The evidence base that we have available to assess those is relatively weak, because we don't typically get this sort of scenario in a developed country. The UK HSA I see are on the line, and they're better able than me to comment on the long-term direct effects. At the moment, I believe the assessment is that the likelihood is low, but that the concern is growing with the duration of this situation. And I'm sure Katie will be able to comment on that a bit further, and Alec. Then you have the indirect health effects. So again, in the short term, we know that residents have been reporting a range of mental health problems, so anxiety, depression, insomnia among them. That is not unexpected, given the situation to which they are being exposed. Some of those symptoms we might expect to resolve over a period of time. Some might become long-standing, even if this situation is eventually resolved. And then finally, we know that stressful environmental situations cause long-term health problems. There is quite good evidence from all sorts of scenarios whereby stress increases the levels of a hormone called cortisol, and cortisol increases the risk of a whole range of health conditions, particularly cardiovascular conditions like heart disease and stroke. The Wally's Quarry situation is a stressful environmental event, so it is quite possible that we would see an excess of those health problems in local residents. The challenge is that it is impossible, I think, at this stage to quantify the level of that risk. And, of course, the risk might not be seen for years, if not decades. So this is not necessarily a health problem now. This is a potential health problem in the future. And again, that makes the situation a bit tricky in terms of quantifying the health impact and the risk. I hope that's provided a decent introduction and a bit of clarity, Chair, and I shall stop there. Thank you.
Thank you, Richard. Can I bring in our guests? And if we could perhaps hear a briefing from the UK Health Security Agency through Katie Spence and Alec Dobney. Could you give us a bit?
Yes, yes. Thank you, Chair, and thank you once again for the committee to invite us along to this meeting to share our updates on our risk assessments. I'll just share my screen if that's okay, Chair. Got a couple of slides just to highlight the main outputs of our risk assessment that we submitted to the committee. So hopefully you can see that slide.
Yes, we can.
Yes.
Okay, thank you. So just drawing out some of the main criteria. So there's a number of data sets that the UK HSA analysed, and this data is provided by our colleagues in the Environment Agency. I'll just focus on the hydrogen sulfide data over the last month, but going back to September 2023. So this is now new calibrated data provided by the Environment Agency based on new monitoring data from the issues that they had with their monitoring equipment back in September. So this is quality assured data now through till May 2024. And this chart at the moment is showing the percentage of time that concentrations have been above the World Health Organization's annoyance guideline value, which is set at 7 micrograms per cubic metre. And any time that the value is above, the concentration is above that 7 micrograms, you can anticipate that there will be an impact on the local population. And we know that when we set within our report that it's above 1%, you're likely to have considerable annoyance. If it's above 10%, you're likely to have quite considerable, considerable above 1%, significant above 10%. That's how we've substantiated it within our risk assessment. And you can see from the data that there's continuing exposure at the mobile monitoring facility at Gallingale, which is number 9, and at the mobile monitor at the cemetery, which is mobile monitoring facility number 1. And when that odour threshold is exceeded, then we do anticipate to have symptoms such as nausea, dizziness, watery eyes, stuffy nose, irritated throat, cough and wheeze, sleep problems and stress. And the more time spent above the guideline value, the greater the likelihood of symptoms being experienced and consequently impacting on people's health and their well-being. Moving over to the actual concentrations now, the monthly concentrations, which we monitor against the US EPA reference concentration guideline value. And again, you can see here back from September, there's been consistent levels above that value, which is set at 2 micrograms per cubic metre. And so from our risk assessment, the risk to long-term lifetime health cannot be excluded. Therefore, concentrations are above that value. That risk is likely to be small, but as Richard has said, the longer that people are exposed above that guideline value, the greater any potential risk will become in the future. We were concerned at the beginning of the year as we moved into winter that those values were on a trajectory upwards. From October 2023 through to February 2024, you can see those concentrations becoming elevated. Since March, they're slowly coming down. This is May's report. We have June's report just at the point of publication. And that does demonstrate that concentrations have come down a step further since May. So the risk assessment, as it stands at the moment, we recognise that there's continuing exposure to the population around the site. People living around the site are likely to experience those ongoing health effects that we've mentioned. And also individuals with pre-existing respiratory conditions are likely to be more susceptible to those effects. With continuing exposure to these effects, these may be prolonged, but not necessarily anticipated to continue long term once those concentrations of that exposure has ceased. And it's back down to what would be acceptable levels. And then just in summary, and this is summarised again in our risk assessment, I've just pulled the main summary out, that there is this continued exposure. It's not possible to exclude a risk to long-term health. Currently that risk is likely to be small, but the longer that the exposure is above that USPA reference concentration value, the greater any potential risk will become. So we are concerned that this is a protracted incident and that monthly averages for the monitoring sites are above that long-term health-based guidance value, and that the odour annoyance guideline value is exceeded for a significant percentage of the time, solely at one of those monitoring sites. And our recommendation is that we strongly recommend that all measures be taken to reduce the off-site odours from the landfill site to reduce the health impacts experienced by the local community. And that's a summary of our report. Thank you, Chair.
Thank you very much for that information. I'm partly alarmed in a sense with regards to that it's not possible to exclude a risk to long-term health. And obviously you're finishing off with a strongly recommendation to obviously reduce or eliminate such odours. It's clearly, as Dr. Richard Harling had mentioned, this has been going on for over 3 years now. And I think it's, well, collectively, with those involved, to me, it's about actions on how we actually respond to what you're telling us, rather than just seeing what may be coming down the road and what we may be doing. So I am concerned, but very pleased that you've been able to make that assessment, because I think it's going to help that action being put into place. May I bring then Environment Agency to make comments, please, before we then open to questions from the councillors. So I don't know who wants to lead on it, Adam, Clive or Neil, but over to you, gentlemen.
Thank you, Chair. Adam Lyons, I'll open for the Environment Agency and bring others in as required. I guess, Chair, I'd like to start by saying we have every sympathy with the local community and remain absolutely committed to maintaining long-term improvements in emissions from the site. And just to reflect a little, the focus of our regulatory activity by the Environment Agency has been around a strategy of contain, capture and destroy the landfill gas. And what I really mean by that is prevent the sort of fugitive emissions escaping to the atmosphere, requiring the operator to take actions around permanent capping of that site to prevent these emissions, some improvements and temporary arrangements while they still import material, improvements in their gas management system infrastructure, as well as improvements in their management systems in terms of the materials and waste that they accept. I guess if I look at this structure, this strategy, you know, that has resulted in notable improvements between February 21 and the end of 2023. These have been acknowledged by partners and the community and have been corroborated by the trends in the monitoring data. However, we also recognise that over last winter, there have been again an increase in emission levels, which notably and appropriately, understandably, caused concern within the local community. And hence the fact, we've taken action earlier in this year that required Wally's Quarry Limited to take necessary steps to manage those emissions. Again, we did that under a formal notice, which we ensured they complied with fully before removing that. I guess I'd also like to say at this point that we are and will constantly keep under review all of the regulatory options that the Environment Agency has. We do constantly reassess the risk of long-term pollution and what that means in terms of the actions we can take as a result of that. And we will continue to keep and take account of UKHSA's long-term advice, and our regulatory activity has and will remain directed to reducing releases of all landfill gas, including the hydrogen sulfide. I'll probably just pause there, Chair, to see if there's anything my colleague Clive Wall, who's our Senior Regulatory Officer, wishes to add to that. Otherwise, we're happy to take questions.
Not particularly at this stage, Adam. I think you covered that in a general overview. Unless there's any specific questions that come up, we can answer as they arise.
Thank you, Chair.
Okay. I probably just actually want to kick off with respect to can we have an update on the old data which needed collaborating? I think that might set the tone as well for the meeting and questions, please. Is that possible?
Yeah, of course. I can give again a brief overview of the collaboration piece and where we are in terms of the release of that information and report. So I guess just to summarise briefly, we appreciate that the calibration issue that was identified in relation to the hydrogen sulfide analyzers within our mobile monitoring data will have caused disappointment and concern in the community, and I'd like to reiterate our public apologies for the fact that that's happened. When we were aware of the calibration issues, we immediately put into place some testing and some calibration, and post September 2023, that calibration means that the data going forward is adjusted and is right. Looking back to the period before that, part of what we did was proposed an adjustment method, and this was put to DEFRA's Chief Scientific Officer for an independent peer review. We expected those peer review findings to be published in early 2024. Unfortunately, that they haven't been published as yet. As soon as they are, then we will outline our next steps, including what is possible in terms of adjusting that historic data and how we will engage then with the community regarding that.
Thank you, Adam. Okay, I'm going to open it up now to the floor. Indicated from Julia Jessel and Steve Norman. Councillor Jessel.
Thank you very much, Chairman. Thank you very much, gentlemen, for your presentations and the information. As you can imagine, and I can only imagine what people are going through living with the smell of rotten eggs, that the local population in that area are tired and fed up of hearing various organisations talking and not much action. I appreciate that actually some actions have taken in terms of controlling the gases on site, but still hasn't cured the problem by a long chalk. At our last full council meeting, Councillor Derek Huckfield did mention about a significant amount of effluent emanating from that site. particularly I would imagine with the wet winter and spring that we've had. So I would like to hear from you gentlemen as to, oh, and I do apologise, Katie and ladies, beg your pardon, you know, what is the significance of this effluent, if any analysis has been done, and if there's any prevention, because any such effluent getting into watercourses, I would imagine, would be of concern to the Environment Agency. In terms of where we go from here, you mentioned the UK HSA overheads mentioned that all measures should be taken. What measures can be taken over and above what's already been done? You know, this is a problem that's been in the making, I think, for quite a long time with the materials that have been deposited in that site. I'm not sure what else can be done, and I would be interested to know what other measures you feel can be taken. And I'm a great believer we should all learn from lessons. And when you look at an overhead Google map of the site, you wonder whether in the future there should be a bigger, and I know around sewerage farms they're referred to as cordons sanitaires, but certainly with any such similar sites, there should be a larger area where development, certainly residential development, is not allowed. Whether it's cordon sanitaire or whether it's any other reference. But I do think in the future that we should try and prevent this conflict between people trying to live a healthy life in their homes next to a site like this, because I don't know what the long-term solutions are. But as I say, if all measures haven't been taken so far, what other measures can be taken? Thank you, Chairman.
Thank you very much, Councillor Jessel. Who would like to open the answer to that?
Thank you, Chair. Shall I start with that? I'll probably take them in order if that's okay. So I think if we pick up the effluent question first, Clive, perhaps you can offer some insight into that, and then we'll go from there.
Yes, I'm unaware as to exactly what specific meaning Councillor Uckfield, I think you said, mentioned about effluent, but if I'll talk to you about what liquid is generated on site and how that's handled and disposed of from site. First of all, the site pumps groundwater from beneath the site. So this is groundwater that's naturally in the environment. There is a pump beneath the engineered liner of the site that will pump uncontaminated groundwater into a storage lagoon on the site, where it's allowed to settle to ensure that there's not any, in particular, particulate matter, solid matter, before that is discharged into the Silverdale Brook that is controlled by the environmental permit, and there are conditions set on the discharge quality of that. But that's uncontaminated groundwater that doesn't come into contact with the waste materials. Obviously the site also has to deal with rainwater, and if that falls inside the landfill contained area and percolates through the landfilled mass, it percolates through the mass, is collected at the bottom of the landfill site and is extracted from the landfill site via a series of leachate wells, which pump the leachate collected to the on-site, well, first of all, it goes to an on-site storage tank, and then the leachate is either fed into the on-site leachate treatment plant, which treats the leachate to a point where it can be discharged into the foul sewer, into the public foul sewer, and that's permitted by Severn Trent Water, who have a discharge consent to allow that material, or indeed, depending on quantities and capacity, they might directly discharge or have that leachate tankered away. So an external contractor will come in with a 20,000 ton tanker vehicle, connect up to the leachate tank, and it will be pumped into the tank, and it will go off site to another permitted facility for treatment. So there is, permit certainly doesn't allow any discharge of contaminated effluent into the environment. I don't know if that goes some way towards answering your question.
Thank you.
Yes.
Allow the member to come back. Sorry, thank you.
Yes, it does, but can I just ask for confirmation who monitors that process, which obviously is quite comprehensive, but obviously involves the Environment Agency, Severn Trent. Is that monitored to ensure that the process is adhering to the various regulations?
Yes, it will be monitored. The discharge to the foul sewer is clearly permitted by Severn Trent, and that will be up to Severn Trent to enforce compliance with discharge consent limits that they will set, but they will monitor that, and they will. I can't speak on their behalf as to how often they do it, but they will monitor the discharges, and they will, police that, so to speak, with the operator. The operation of the leachate treatment plant itself and any discharge of any liquids from the site will be monitored and enforced through the environmental permit that the agency has issued to the operator.
Okay, thank you very much. Councillor Norman. Councillor Jessel, sorry.
It was what other actions can be taken over and above what's already been done, because the presentation referred to all measures to be taken. What else can be done?
I think that's the leading question, isn't it? Because it's actions that we are now looking at.
So shall I start to answer that one, Chair, and then bring in colleagues accordingly? So if I just look back at the actions that have been taken so far by the Environment Agency, we've issued the operator, Wallis Quarry Limited, with 4 Regulation 36 enforcement notices, which effectively compel them to comply with elements of their permit. Those have been effective in bringing a company back to compliance, and those have revolved around some of the processes I talked around earlier in terms of the acceptance of waste procedures, the temporary capping and infrastructure requirements that are required to comply with the permit. In March 2024, we issued a suspension notice which prevented certain deposit of biodegradable materials until certain actions around capping and gas infrastructure have been installed. So there are a range of regulatory tools we've used and will continue to use if that needs to be the case. I'm also aware that other partners, other organisations are contemplating and gathering evidence for their own action. I think some of that has been referred to in some of the materials that you've seen in your pack today, in terms of the local authority and abatement processes. In terms of the Environment Agency, there are further tools that can be utilised, although I would have to say, in terms of things like a closure notice, that would be a last resort option. And to do that, there are some very stringent criteria that the Environment Agency must consider around risk of serious long-term pollution, persistent non-compliance with permit conditions by an operator, And again, understanding how that situation would then need to be regulated going forward. So until 2023 and the end of that year, our strategy to capture, contain and destroy had proven effective, and that had been acknowledged, as I've said previously, and we didn't necessarily believe there was the risk of that long-term pollution linked to the operation of the landfill. We keep that situation under constant review. We're now looking at that in relation to the odour from 2024, the compliance of the company, and the other associated information that's available to us. So those are some of the actions that are available to us as the Environment Agency. I don't know whether anyone else would like to comment on that. Clive?
I think for me, that's...
Sorry, Chair, I was just wondering whether Clive would want to comment on that from the Environment Agency in terms of those tools. Clive?
Yes, certainly. I mean, some of the things you've talked about there, Adam, are enforcement tools that we use as a response. But the basic principle of the environmental permit that we've issued to Wally's Quarry is for the operator to take all appropriate measures to minimise emissions. We're not just talking about gas emissions, but all sorts of things. So it's an ongoing and continual regulation of the operator as the site develops, that they continue to take all appropriate measures. It's specifically in terms of landfill gas that we're talking about. The key components for controlling landfill gas are the operation of the landfill gas management system, ensuring that there is sufficient gas extraction on site that's working efficiently, and ensuring timely capping of the site to minimise fugitive emissions, and that is something that is continually assessed and monitored as the site develops. I don't think I've got anything more specifically to add to that. Is there any specific questions?
Yeah, I don't think we've actually looked forward in terms of actions, and maybe it's the UK agency that might be able to answer the actions that can be taken that might be seen as actually some for residents concerned with those health issues that are raised, that we are looking at action that is going to resolve their problems. That's what I think in terms of Councillor Julia Jessel is looking for and seeking. It's impressive that there's a whole environmental tools and so forth, but these have been already explored for many years, and the net result, I think, if I was to use that as a phrase, is no change, and all the monitoring is still not equivocally giving us a definition of actually what are we going to do to stop it, and taking the effects of the impact on health, because obviously Richard Harling alluded to those list of illnesses that could, I'm not saying will, could occur, is quite worrying for those residents involved. I will bring in Councillor Norman for some more questioning.
Thank you, Chair. I have two questions, actually. I'll start off with the toxicological overview from Public Health England on hydrogen sulfide, and it refers to limited data suggests that effects from repeated exposure are similar to those for acute exposure, with respiratory, neurological and ocular effects at high concentrations, and there are limited data available on the reproductive and development effects of hydrogen sulfide, and at the very end of the summary there, there's inadequate data on the carcinogenicity of hydrogen sulfide in humans, experimental animals, although it refers to another agency. It doesn't have that as an issue. Data is extremely important, and if we want the public confidence, that's got to be accurate. So I just don't know. Maybe it's been discussed before, but what happened? What went wrong that the monitors between March 2021 and August 2023 were faulty? I mean, how could that be? How could that not be picked up at some earlier stage than that? So that's my first question, if that's okay, Chair. Thank you.
Shall I start with that one from the Environment Agency's perspective? So, what was the issue and how did it occur? Essentially, we misinterpreted how the new model analyzer, which is the part of the equipment that we use to monitor the gases from the site, how it should have been calibrated. And I guess this meant that some of the, and this was only for hydrogen sulfide data, I'd like to add there. And this meant that the hydrogen sulfide data collected from those analysers, this was around the country, not just at Wally's Quarry, is likely to have a greater degree of uncertainty than previously understood. How did this situation sort of occur? The Environment Agency switched to new instrumentation in 2016. Obviously, as you can understand, these are complex technical instruments and procedures. And the issue with the calibration wasn't evident from any of the audits that we'd done or during any technical calibration. And again, we picked that up through our sort of routine monitoring in what we call MMF9, which is one of our facilities at Wally's Quarry, and indicated that there was an issue with the analyzer there. So as a result of that, as I've said previously, we then instigated an immediate investigation to understand what was the issue there. That was carried out in September 2023, and over a couple of week period there, did some very sort of intensive scrutiny of that particular monitor, which I said found that the information and the instrumentation wasn't performing as it should have done. And then obviously we then took steps to rectify that in terms of the calibration, and as I've said previously, the adjustment methodology for the long-term data as well.
Difficult question, but I'm grateful for the answer. The other question I've got is somewhat different, which is about the actions to take and so on. As far as I'm aware, there aren't any more actions needed, really. On the 7th of March, Penny Mordaunt, the Leader of the House, in reply to Karen Bradley MP, said everything was being done, it is being resolved. And on the 14th of March, the Minister at the time, Stephen Barclay, said, I know that everything that can be done within the law is being done. So I noticed that phrase, within the law. So I suppose my question would be, if there's a wish list, and I don't suppose it's in this committee's prerogative to grant it, but if there's a wish list, is there anything that any of the speakers here, the witnesses today, would like, they need or would want to actually resolve this issue with Wally's Quarry? Because clearly it can go on forever by the sound of it. I mean, is there anything that you would want from Parliament, which we could lobby on, that would help your case? That's essentially it.
Okay, thank you, Chair. I guess from the Environment Agency's position, we are seeking a sustained and long-term sustainable solution to the issues here. It's inappropriate, I think, of us, or me particularly, to comment further on any tools that DEFRA government might be considering in terms of future regulation or giving us those changes in powers. Equally, we have to respond to the performance of the operator in line with their permit. That's what we can do, that's what we are doing, and that's what we will continue to do in terms of the tools that we have available to us right now.
come back briefly to that, because that means the reputation of the Environmental Health Agency is at stake here. But even if you don't want to say publicly what extra regulations, laws that you would want, can you confirm, please, that you are doing that privately as a body, if needed, if you do think there's any needed? That's all I want. Some reassurance that there is going to be some progress, and this committee is not going to meet in a year's time and have the same conversation, really.
So as I said, we continue to keep all of those regulatory options open. We continue to speak to DEFRA, our sort of sponsoring parent department, in terms of the opportunities and options we have available to us. As I've said to you before, you know, there are some longer term or some options that are available in terms of closing the site, but they come with some stringent criteria that we must meet within the regulations and within the law, as we've said, that enable us to take those actions. Those are last resort options. However, as I said, you know, we keep all of those options open and constantly review the situation. You know, return of unacceptable odour, persistent non-compliances of the operator are all things we consider within that process, and we will continue to do so.
Thank you. I'm going to move on to Councillor Janice Sylvester-Hall, and then I've got Councillor John Jones.
Thank you, Chair. Prior to getting involved in this, and thank you for the reminder to Dr. Holling, it was 3.5 years ago that I drove up to Newcastle-under-Lyme for the first meeting that I was involved with, and I took the time to go round to each of those monitoring equipment locations and just stood outside my car and thought, if I was living here, how would I be feeling right now? And it's no sort of irony on the hottest day that we've had so far that the windows were shut on houses and children weren't necessarily playing outside because one was right next to a play park. And I thought, how would I feel if that was my family? So to then find out that we don't have, and I think one of the colleagues has mentioned it already, confidence, and in some cases I would add to that trust in the information that I was being told if I was a resident of that particular area. It must be intolerable to think that that is how you're living and what you're exposing potentially your family to. So my first question from when I was back at Newcastle-under-Lyme recently, was there anything, any relevant information that we know as to why the Environment Agency weren't represented at that meeting before I continue?
Sorry, you have to be a little bit more specific in relation to which meeting you attended. I'm sorry, you can be a bit more specific.
Okay, so it was a health and care overview and scrutiny, so this meeting that was held at Newcastle-under-Lyme, and with regards to Wally's Quarry, which was the sole item on the agenda, which I believe it was November when it took place, but the Environment Agency weren't represented at that meeting. I'm assuming that you were invited. Yes, you were. I'm being told you were invited, but the EA was not represented there. I just wondered if there was a reason as to why that was the case.
I guess from the Environment Agency's perspective, we'll always try to accommodate any public meetings or any committees where that's possible, and equally answer any questions that are relevant and appropriate for us in that space, as we have done today here. There will be certain situations where we feel others might be more appropriate to answer those questions or can offer better insight into the issues, particularly around public health. And you know, as we see today, we've got UKHSA here with us. They can often offer much better insight than we can around the public health issues of any particular issue. But equally, as I said, we are, where we can, more than happy to attend meetings of this nature.
Okay, I think there's an area of dissatisfaction from members, and I do recall the day. But I don't want to spend too much time on that. I think, obviously, if there are any future meetings, no doubt there will be, that your presence would be required. Councillor Sylvester, have you got anything to come back on? Yes.
Yep. Yeah, I think at the time, because of the issues of the calibration of the equipment, that we had a lot of questions that we did want answered, and it would have been the EA that needed to be in the room to be able to do that. So I do appreciate having the opportunity to speak with you today, but it goes back to my original comment about having trust and confidence. For those residents in the community that are living in that particular part, that we have that information when we need it. So far we've been told that there's been enforcement notices, suspension notice, and the recommendation that we're looking at in the report today is saying that urgent and decisive action needs to be taken. Is the necessary step to issue enforcement and suspension in itself deemed non-compliance?
I guess I'll answer that in summary, and then I'll bring Clive in to answer specifically. I guess the long and the short of a question like that is we don't issue regulatory notices and suspension notices for companies that are complying with their permit. We do it as a result of non-compliance to achieve compliance with those permit conditions and to ensure that, as Clive said earlier, those appropriate measures that are required by operators are being implemented to ensure they comply with their permit. That's the sort of summary overview from my perspective. Clive, is there anything specific you'd like to add to that?
Yeah, I'll just clarify. Yeah, we would be taking enforcement action to put right, a non-compliance with the permit. So I think that's the answer to your question. If an operator is not complying with their permit, there's a range of ways that we could address that non-compliance. From simple advice and guidance, all the way up to issuing enforcement notices and potentially pursuing, prosecution ultimately. I think I'd also like to say that the suspension notice that we issued in March of this year was not connected with non-compliance with the permit condition. It was connected with the risk of odour pollution outside the site, causing serious pollution. It wasn't connected with a breach of a permit condition. So there is one important distinction there for that particular notice.
So between the data that we're being given now, which has been deemed reliable, but still showing that the recorded data is over what the World Health Organization is saying it would be acceptable for odour annoyance, the information that we've been given about what the physical impact that could be on health of those people who are living in the area, as well as the psychological impact, which for me would be absolutely intolerable. Why aren't we actually at the point now where we're doing that other actions? If we're saying that it's a last resort, surely 3.5 years of me participating in these, let alone what's being done by others prior to that, how long is it going to take till we get to that point when we need to do that? We're suggesting in this report that we take an urgent and decisive action. My goodness me, if we're not at that point now, and we need to look at the next one, which is stop it. Stop it happening now. If we're not seeing any absolute impact on that data coming through at this point, having taken the lengths that we have now, surely we're at that point.
I think that's the crux of why we're here, and I probably think that you don't have those answers, but I'll come up into my summary when we close the what I think we should be doing as a committee. I'm mindful of time, colleagues. I'm happy to run over if you are. And I've got Councillor John Jones, please.
Thank you, Chair. I will be brief. What I was going to say has just been said. Surely to goodness, 3 years in, no improvement. We're at the point now where we've got to issue some sort of ultimatum, either stop it or stop it altogether. You know, it's appalling. I just can't imagine how awful it must be to live next to this mess. And we've talked a bit today about lack of calibration on sensors and one thing and another. I suspect the people that live there will tell you, I don't need a bloody excuse me, you don't need a sensor. I can tell you your sensors are wrong. Because, you know, I have to live with it every day and my kids can't play out. For goodness sake, let's put some teeth into this and let's get it sorted out. Thank you, Chair.
Thank you, John. I think that probably sums up our sentiment from us all. So I think what we've gained from here is that obviously trying to deal with those health issues and the long-term impacts. Action is required to avoid those long-term impacts and of what may have already been the damage caused. I mean, I'm probably a bit concerned actually about gases that aren't odorous in terms of and very poorly detected, whether there's some impact from them as well. But this could go on in terms of a wider conversation. So it probably does need, and I think if the committee are happy for me to do so, I think there's a need here to write to the Secretary of State for Health to try and draw this to a conclusion, because it is health that matters here, and I'm not too necessarily satisfied that we've necessarily got those that we can help us to conclude where we're at. Charlotte Atkins.
I think also we should write to the Environment Secretary.
And that is exactly what we also need to be doing. So I thank you for that intervention. That is something I would say that we are writing to both Secretary of States, because I think it needs to be brought to a higher level, because it's clearly residents require action, and for 3 years all they've heard is rhetoric with no end result.
Don't forget to welcome them to the new job at the beginning of your letter, of course.
Absolutely. But I hope they'll respond and not say that we're just settling in. So I think we can say that we've given that a pretty good going over on that. Folks, thank you for your time, and I think in a sense some candid responses, but not necessarily the ones that we were probably looking for in terms of the health impacts. So I'll go back to what I said right at the beginning, that I think the UK Health Agency's recommendation is possibly what we're looking at here, and that it's hopefully with the Health Secretary, along with the Environment Secretary, will actually have to take your recommendation, and we might see action. So thank you very much for joining us. Do appreciate it, and enjoy the rest of the day. We're okay. I wouldn't like to think what the people of Silverdale are thinking. And I think that's where our hearts and minds need to rest on what they're having to put through. So this is where we are representing them. Okay, I'd like to then move on, and I'm sure we'll, in terms of the membership here, Item 7, the district and borough health scrutiny activity. Is there a borough district who would like to make a comment? Councillor Norman?
Only because it looks very thin on there, but for Lichfield District, it refers to the 23rd of July, and on the 6th of June, and then later on the 23rd of July, we're sort of scoping for a health scrutiny task group. Not talking anything in particular at the moment, but to actually be able to respond in detail for future issues locally for Lichfield District. And the other one, part of that as well, is that the great success of the Disabled Facilities Grants service that we're able to do, and taking it in-house and actually made some big improvements there. So obviously that's going to help prevent falls and all the rest of it. And that's but also we're all keeping an eye on the County Council doesn't take our better fund away yeah, they might do.
Thank you, Councillor Norman. Councillor John Jones?
Thank you, Chair. Just a quick update then. The annotation on the document packs is a little out of date. It said, I think it just says we're meeting again on the 13th of March. We did meet on the 13th of March and we did discuss the stuff that's annotated. We also met again on the 10th of July and we had an update. We had a presentation from the Harplands on mental health provision. And we meet again on the 25th of September and I can't remember what we're going to be talking about, so I'll have to leave that blank for you for the moment. Thank you.
Thank you, Councillor Jones. So on that note, I'll quickly move on to the item 8, the work programme. Can I ask for your permission? The 30th of September, I'm not really available on that day, and I was wondering whether that could be brought forward a week to the 23rd of September. Would that be a problem, Zach? And with members and committee members, if we were looking at the 23rd of September.
Yeah.
Yeah. So, would that be okay? Because I understand from the police panel will have put a request in to swap as well. So it actually would tie in with what I've requested in terms. So we're okay with that movement. So Zach, over to you on that, and thank you very much for that. And then the only other movement, again, before my elevation to this role, I will be on holiday for the January meeting, and I'm wondering whether that could drop into February when I'm back. Again, committee, it's your decision. It's either that or I lean on my vice chairman. That's right. That's the question. That's the question. So we'll come back to that one. But thank you for the 23rd of September. Do appreciate that. Okay. On that note, if there's nothing else on work programme.
Just mention that I had to go to Germany in my previous authority in North Warwickshire, where a very expensive estate was built on a dump, which is actually, they've all got methane monitors in there now. The council was against that, but ruled by the Secretary of State at the time. And down below them, in the dip, was the animal rendering plant, whose smell was never forgotten. You would drive through the village quickly with the and that go to Germany.
Okay. Yeah. No, well, I hadn't closed the meeting. But I will now close the meeting, being no further considerations to take on board. So at 4 minutes past 1, I formally close the meeting, and thank you for your attendance.